This is basically the kind of clinical presentation that we see. Among infections, and this is from worldwide data, but among infections, we find about 30 to 40% are completely asymptomatic. They never even know that they have infection. Some places say as high as 50%. Now, the remainder are symptomatic, but their disease can range from fairly mild, which is most of them, probably about 80%, where they have fever, aches, fatigue, dry cough, very much influenza type symptoms, which, we see every year. Then there's a smaller subset, probably in the ballpark of 20%, that get short of breath and have low oxygen in their blood. Those patients are typically needing to be hospitalized. And then there's a small subset, 10% or so in some case series. Some people have said as many as 30% in other places. Depends on the age of the patients. What we found around where I am, about 5%. But these are the patients who get very sick. They get overt pneumonia, viral pneumonia, and they get what we call ARDS, which is adult respiratory distress syndrome, which basically means the lungs get completely whited out. They cannot breathe on their own, and they need some degree of respiratory support, that is a ventilator or something like that, with very high levels of oxygen. There's also a subset of patients, it looks like, we don't have a lot of great data on it, who perhaps have mild disease initially, but then end up with chronic symptoms. And this isn't really well understood at this stage, but that is something to keep in mind. Now, the risk factors for progression to very severe disease and in fact death, advanced age. In Canada, you know that a lot of our deaths occurred in elderly people in nursing homes and stuff, and that's been pretty much seen right around the world. Once it gets into nursing homes, once you're talking about a large group of patients that are 70 to 90 years old, you're going to have a very high fatality rate there, probably 30% plus. It is a very severe disease. And similarly, among those with comorbid disease, so lung disease, heart disease, kidney disease, dialysis, hypertension, even diabetes, smoking, obesity, which we don't think of as major comorbidities, also put you at increased risk. Now, the question comes up is, when do we get a vaccine? I mean, we really want to go back to our regular life. I want to get back to my regular life. I'm sure you guys want to get back to your regular life. It'll probably happen when we get an effective vaccine. There are about 165 vaccine candidates out there, at least 30 that are in various stages of human trials. But we need to determine safety and effectiveness, and you need to get regulatory approval. And then there's a whole bunch of downstream things that I'll talk about as well. But, there really isn't a solid timeline. When I say there's no solid timeline, no defined calendar date, the simple answer is, when are we going to have a vaccine? When we show that it is safe and effective. But what most people are asking really is, when will a vaccine be accepted as safe and effective? When will it be available for a person like me? And also, as I said, when will vaccine uptake and disease progression in the population sufficient to resume life as we knew it pre-pandemic? So that's a little bit harder, and there are things to kind of consider with that. Typically for standard vaccine development, you go through 3 phases. You have phase 1, which is basically animal work. You go to phase 2, which is human work, where you're not measuring outcomes, at least clinical outcomes for the most part. You're measuring symptoms. You might be measuring immunologic response in blood, that is antibodies and such. And then finally you go on to phase 3, which are the large studies, where you're basically trying to determine whether the thing works in a real population. So there are actually about 4 candidates that have just started phase 3 trials, but that makes you really optimistic. If you're like Donald Trump, for example, well, it's great. But in fact, we need to wait on the trial results. We need to get approvals. You need to produce the vaccine in large amounts. You need to distribute it to a whole heck of a lot of people. You need to get it into clinics, and then you need to get it into patients. So that's a much more substantial process. So it's probably not realistic that a vaccine going through standard approaches is going to be here really soon. I would think that it would be at least, at best case scenario, that it would be widely available by summer of 2021 kind of thing. And further, there's no guarantee that the vaccine is going to be 100% effective, like we have for measles, for example, where you get the vaccine and boom, you're immune. It's probably going to be much more like influenza, where you give the vaccine to as many people as you can, and if you're lucky, 60% of them take it, and if you're lucky, half of those get a really robust immune response. So don't depend on the vaccine being perfect, but we have a better chance if we have a vaccine. And if, as you all know, we need to get about 60 to 70% herd immunity. So that's between the vaccine and native infection. So what's the difference between standard vaccine trials and human challenge trials? Standard vaccine trials involve taking a wide range of volunteers, everybody that's out in the population, because you want your groups to be comparable to the population, randomizing them to vaccine or to placebo, and then simply measuring how many in each group get spontaneous infection. That is, you're not trying to infect them, you're just saying, go out in the community, do your usual thing, and you see over time how many people in each group get the infection. And you hope that the two groups are comparable because you've basically randomized the patients randomly into two groups. So hopefully the two groups are similar, and if one group got the vaccine, one group that got the placebo, hopefully the group that got the vaccine gets less infection. Human challenge trials are a bit different. What that involves is randomizing a much smaller group of patients, like 1% of the size or 0.1% of the size, into two groups, one of which gets the vaccine and the other placebo, but then all subjects are intentionally exposed to the pathogen, in this case, SARS-CoV-2, and the number of people in each group who become infected is measured. Now, human challenge trials have been used very extensively in the past, probably about 30,000 participants, minuscule mortality rate. Some studies I've said have suggested that formal trials that were approved and regulated had no deaths. It's been used for cholera, malaria, tuberculosis, typhoid fever, whooping cough, dysentery, strep throat, influenza. It's been used for all of those, and I'm sure there's some that I'm missing. Now, all of these either had effective treatments, antibiotics in particular, or had a very low fatality risk like influenza, although clearly in influenza there is some mortality risk. How can you compare them? Well, standard vaccine development, as I said, you have a phase 2 period where you have a smaller group of patients, then you go into a very large phase 3 in which you measure outcomes. Phase 2 is markers, secondary outcomes like symptoms or immune response. In human challenge trial, you're actually doing both of those at the same time. This typically takes years. Standard vaccine development in the past, they've tended to take 5 to 10 years. I think the fastest one, it was 3 years, I think, maybe 4 years. But human challenge trials you can get done in months. For standard vaccine development, you need trials with on the order of 10,000 patients in the study, and some have been larger than that. For a human challenge trial, you need 100 people ballpark, or less than that, per vaccine. One advantage of a standard vaccine approach is that it's going to be, because you use a very large population, and if you demonstrate that it works in that large population, you can look at the subgroups and say, it really works well in this group, but maybe in the elderly it doesn't, but it gives you information on a wide range of people that it might work in. Now, on the other hand, human challenge trials, because especially in this case, you have a disease for which there is no really solid treatment, you want to have the people who have the least risk of having adverse consequences, including death. And so the vaccine result will be directly applicable to that group of people. Maybe it's 18 to 25-year-olds. But on the other hand, you would have to infer that it will work at least to some level in other age groups. And that's okay. That's okay, because you'll find the same thing with regular vaccines, is that they work really well in terms of an immune response in young, healthy people, but older people or debilitated people, chronic disease people, they have much less of a robust response. And remember, even if the individual doesn't develop the immune response. If you can get it out in the community enough, it will help the community get herd immunity, and that'll protect those people who might not be responding otherwise. So what are the risks if we do this? And I gave this a lot of thought, as I know that you have as well. But when I look at it, we are losing, as you guys have mentioned, just United States alone, 1,000 people a day. Canada, we're probably losing 80 to 100 a day. Probably internationally, must be in the ballpark of 5,000 a day, right? Deaths. So if we can move the time that it takes to get a vaccine out there earlier by 6 months or 3 months or 2 months, you're talking, or even 1 month, you're talking 100,000 lives plus. What's the downside? What's the comparison? Well, let's take a look at I think the most comparable thing is living donor liver transplant. Now, they do about 350 to 500 of those a year in the United States. In living donor transplant, you take a part of the liver from a volunteer. Doesn't have to be a family member. There are people who do this altruistically for just a stranger. But you take part of the liver out, and you transplant that into another person who needs a liver, and the donor liver typically will grow back and be perfect, and the donated liver into the recipient will also do well. But let's get some idea of what the complication rates of doing that. Now, I want to emphasize this is completely accepted in the Western world. Any place that has the resources to be able to do this, it's thought to be ethically justifiable. So, the most recent study I looked at suggested, and this was a review, so it combined data from a lot of studies. 30 to 50% have at least one significant complication. 15 to 40% have a life-threatening or serious complication. 1.1% of donors have lasting disability, and about 1 in 20 or 1 in 23 will actually die. All right. What happens with SARS-CoV infection? Well, with SARS-CoV, yes, you have a 3% overall death rate. So if we gave people SARS-CoV to everybody, we would have a death rate, of about 3% among all volunteers if they were in the same spectrum of health as the regular population. But that's not who we're going to focus on. We're going to focus on the youngest, healthiest people, and the numbers suggest that the risk of death in this group, 20 to 30 years old, is less than 0.3%. South Korea showed 0.2%. Another country showed 0.22%. And if you go even lower in age, 18 to 25, which is who is recommended if we're going to do challenge trials, you get to even a lower mortality risk. So as far as I'm concerned, these are completely comparable risks if you take the vaccine. And in fact, I suspect the vaccine that will be used for challenge trials will be a somewhat attenuated virus and less inclined to cause severe disease. That's what they're trying to generate right now. But even if we used the virus that's out there, you're still talking in this group of patients, you would expect less than a 0.3% risk of death compared to 0.4% if you chose to be a liver donor. Excuse me. Uh-oh. So that's all I've got for you. I think it's a completely reasonable approach, and I think that at a minimum we should be ready to do this and to be able to pull the trigger on short order. Thank you.
Thank you so much, Dr. Kumar, for that very, very fascinating presentation. And now I'd like to give the floor to MP Powlowski to speak before we move into an audience Q&A.
Hello, thank you. Maybe just, I wanted to clarify something with Anand first of all, but I think you said less than 0.3% risk for 18 to 25, but that's in all comers, right? And you haven't included or factored in there a lot of those people who do get more sick, who are younger, have underlying disease, right? I think the numbers I looked at least 50%, if not a lot more of those.
You're absolutely right. I took that number from all people in that age group, but if you then selected out and remove those that had chronic illness and other things, which would be a significant subset, you're absolutely right. The number would go even lower, but I thought just in that group alone, it's already lower than liver transplant, for example.
Okay, thank you, and thank you to One Day Sooner for having invited me. Is this thing looking? Am I getting on this? I see Anand still. Are you hearing me?
Yep, you're good.
Okay, so I am happy to be here, and having said that, I've been doing a lot of this kind of thing, and of course, being a politician, I always say something like, I'm really happy to be here. And I pride myself in being somewhat honest as a politician. I don't think I'd say that if it wasn't to some extent true, but I got to say a lot of times, if I had my choice, I'd be doing other things, but that is not the case with One Day Sooner. I am genuinely very happy to be here before you. I have a lot of admiration for your organization. And I have to say, I'm very proud to be able to present your petition in Parliament somewhere towards the end of October, I think. Let me start off by saying something that I think everybody knows, but I really don't hear enough of, which is our number one priority as a country is to get a vaccine. Our number two priority as a country is to get a vaccine. Our number three priority as a country is to get a vaccine. I think our number one priority internationally is to get a vaccine. And we don't hear that enough. Now, there are, and Anand said 4 vaccines. My understanding it was 10 to 11 vaccines now currently in phase 3 trials. Perhaps one of those will turn out to be a godsend and will be the vaccine that works really well. However, that may not be the case. My understanding is most vaccines, in fact, fail. And if that's the case, certainly challenge trials would seem to me to be the way to go. Now, I know in talking to all of you, I'm preaching to the converted, but I think as all of you realize, the fact that this makes sense depends on the fact that COVID-19 in that subset population, young people 18 to 25 with no underlying diseases, is a much more benign disease than it is in elderly people or people with comorbidities. And we really have to emphasize that and continually emphasize that and continually give them the numbers. As Josh said, I think the numbers I heard, the case mortality rate in that population, 1 in 20,000. I read something from the BBC that was saying 1 in 40,000, according to a stats person they talked to. I think we have to keep re-emphasizing it and the small number of people required to do such a trial. So when I'm talking about this to my fellow members of Parliament, I say, do the math. This is the risk of dying. This is the numbers who are being affected globally as a result of COVID-19. But I think a lot of people don't do the math. A lot of people don't understand it. And when I posted a link to that petition on my site, I'm getting all kinds of emails, and I looked at where they're coming from. They're coming from all across Canada. And I think they're anti-vaccine people. And some of them are very nasty, saying, MP Powlowski, you piece of shit, why don't you give yourself the virus and your whole family, and hopefully you all die, and then we can vote conservative or something. Now, though actually, I haven't heard anything negative from the conservatives about this, but there are a lot of people, I think, who are basically anti-vaccine, period. And they oppose challenge trials because they oppose absolutely everything with regards to vaccines. But I do think that when we talk about it, we have to stress the numbers, because a lot of people don't understand this. The only reason we're advocating this is because in young people, it's a much more benign disease. Now, some people say it's unethical. And I think some of the people that say it's unethical are simply, to some extent, misinformed. So one of the arguments that I've heard for it being unethical is there's no rescue medication. Well, within that population, my understanding is the risk of death is approximately the same as common influenza. And in common influenza, we've done challenge trials apparently for a long time, including in the development of Tamiflu, Ostemivir. Now, they say, okay, we have rescue medications in influenza. Well, no, not really. Tamiflu is not a cure for influenza. It makes you get better like 6 hours earlier or something. I don't think it prevents any of the serious complications of influenza. And hopefully shaking his head. So, and there's also been a lot of concern about adverse effects and the fact that the company may have underplayed those adverse effects of that medication. So, okay, you say there's no rescue medication with COVID-19. Well, there's no rescue medication for common influenza either. And there's remdesivir and there's dexamethasone, which have been shown to have some benefit. So I think those people that say, well, there's no rescue medication, you can't do it, I think are just wrong. I think more importantly to me, and what really, really goads me, is the argument that it's unethical because somebody here could possibly die or somebody could have long-term health effects. And certainly as someone who's advocated it for this, if we have challenge trials here, and if someone was to die, unlikely as that is, or if someone was to have long-term adverse effects, of course, I would feel very badly. I would have to wake up at night and think, oh, did I do the right thing? And Ann and myself being doctors, we're used to that. I mean, that's part of our life, you know, that when we're treating people, hopefully every time there's an adverse outcome, we're always questioning ourselves and saying, well, maybe I should have done that. Maybe I should have done, and if we think there's something we could have done better, that haunts us, and it haunts us for a long time. And that's one of the reasons I'm really glad as hell I'm not still doing acute care medicine after 35 years, because those are the things that wake you up at night. So certainly if they're adverse outcomes of challenge trials, it's going to be disturbing. However, the chances of that are quite low. On the other hand, the death and morbidity and mortality due to this pandemic is very real. And volunteers want to do this. People who make vaccines want to do this. The only reason we're not doing them is because there are people in society who say that this is unethical, actively preventing us from doing that. And I think those people who are so willing to throw this at us and say, what you're doing is unethical, I think they have to accept the fact that by their actions, they may be perpetuating the pandemic. And okay, maybe we don't see them right in our backyard, but we are starting to, with the second wave, even Canada, seeing those deaths in our backyard, but we're certainly seeing them globally. And if you say, well, it's unethical to have a death in Canada, well, how about all the deaths in Peru? How about all the deaths in India? How about all the deaths in Mexico? How about the 7,000 healthcare workers globally who've died from the pandemic? In addition, that doesn't even include all the other deaths related to this pandemic. So for example, there was a letter in the Lancet, an article in the Lancet, which was, it's speculation, but saying that they figured that there would be 1.2 million additional worldwide deaths under 5 years old as the result of the pandemic's effects on the healthcare system. Kids not getting immunized, people with HIV, tuberculosis, not getting their medicines, people not going to the health center clinic when their kids are sick because they're worried that they're going to get COVID when they go there. Or the other thing is, and a very major thing is, the ILO, International Labor Organization, has stated that they figured the pandemic could drive 500 million more people globally into poverty. And according to the World Bank, they thought that economically, globally, the pandemic could put 40 to 60 million more people into extreme poverty. And I've worked quite a few years in developing countries where I've had people come to me and say, I can't continue to pay my $1 a day to keep my chronically sick kid in the hospital. So you're out of a job, because of the pandemic, and you don't have the money and you can't bring your kids to the health center, those kids die. So this is all the very real adverse effects of delays in producing a vaccine. And yes, I mean, I'd rather not do challenge trials at all either. I'd rather have a quicker outcome, but this seems to me to be the quickest way and the best way to get a real result, should we not get, with the current drugs that are in phase 3, a quick answer. Lastly, let me say, I am truly impressed, Josh, with your organization and the rest of you at One Day Sooner. The only reason I know about challenge trials is because of One Day Sooner. I think I read about it in the New York Times and read about your letter from the scientists and the Nobel Prize winners. And I started reading and I started talking to people like Anand and various other people afterwards. And I have to say, since being a member of parliament, which has only been a year, I've often talked to youth groups, and I'm often disappointed with the youth of our country and talking to them for a couple of reasons. One, they seem so self-absorbed with their own problems. I mean, it's all about, it's all about me and it's all about my problems. The second is what would seem to be an almost total disregard for the plight of poor in other countries. It's all about like how Canada is going to hell on a handcart and how everything is falling apart and everything's getting worse in Canada. And they seem to have absolutely no knowledge or understanding or sympathy for people in other countries. So to see One Day Sooner, to be ahead of the curve in terms of thinking about this, and these are young people, and some of you, like I think Josh, not people who are scientists, but to be ahead of the curve in pushing science and pushing knowledge in the right direction is really impressive. People who don't put themselves first, people who put the interests of others before their interests, who are willing to make a sacrifice, people who have a global vision and are concerned as what's happening in the world. This is a pandemic. This is something that's affecting everyone in the world. And it's something that I think when we're addressing, we have to keep that in mind, that this is a global problem that should be bringing humanity together, and it should be bringing humanity together and solving this problem. And the fact that, Josh, you started this organization, which I think has pushed us to One Day Sooner, I think is really tremendous. And all of you, keep up your great work. And I'm proud to present your petition in Parliament.
Let me second that. I think that all of you young guys who have been involved in this ought to be applauded. It's a very impressive thing.
Thank you so much, both to MP Powlowski and to Dr. Kumar. Josh, I just saw you unmuted yourself. If you wanted to say anything.
Oh, I was just going to say thank you as
Yeah.
well. That's very, very kind words, and we really appreciate it.
Yeah, we do really appreciate it a lot. And of course, we are incredibly honored to have you both here for tonight's event. Just before I ask some questions that the audience has submitted through the Google form, I am going to send a few links to the chat, and don't worry, I will also send all of them in a follow-up email, so you don't have to frantically bookmark them or anything like that. I'm first linking the petition that MP Powlowski referenced. This is a petition that MP Powlowski has co-sponsored. It was actually written by Alexander Rogers, who is our petition organizer in Canada, on the call, calling on the government to announce a plan to conduct COVID-19 human challenge trials. And it currently has just north of 300 signatories. We really want it to get 500. That will ensure that it is submitted to Parliament. Of course, we really want it to get 1,000 to really signal the support for Canadian COVID-19 challenge trials. And so if there's one takeaway from this call, it's please sign that petition and please share it widely with friends or family. I'm also linking a web page that we have on our website that's specifically dedicated to the Canada petition and has easy resources to email the petition to your friends or post it on social media. That would be a huge help to get this discussed in Parliament. So now I'm going to move on to just a few questions for the panelists before we move into optional breakout rooms where we can socialize and talk about challenge trials and other things. The first question that I wanted to ask is from Helen, who's on the call, which is, does Canada have suitable quarantine facilities to conduct a challenge trial? And what are the prospects of a challenge trial specifically in Canada? I think maybe Dr. Kumar, you might be able to touch on this question as well as Powlowski.
Yeah. The first part I can touch on. Basically, to do a trial like this, you talk about isolation areas. What you need is a ward of a hospital, basically. That's that's kind of isolation you need, because this isn't any different than what we see with spontaneous disease. So there are all sorts of decommissioned hospitals and hospital wards that can be used for this thing quite effectively. So I don't think that's a substantial problem if we think creatively. Now, how likely it is to occur, I'm going to throw that one to Marcus.
Well, I have to preface my words by saying I am a politician, and I do want to stay being a politician and not thrown out of my own party. But I'm not sure. I have in coming to my own opinions whether I believed in the idea of challenge trials. I did talk to people who involved in developing vaccines in Canada. I know that there is an interest. I don't want to say anything more about that because I'm not sure that they want me to reveal what, if any, plans they have. However, there is an interest. As some of you may have heard, it's been pretty widely reported, starting with the Financial Times, which I think is as reputable a newspaper as there is in the world, that the United Kingdom would start challenge trials beginning in January. My belief is that once one country has kind of gotten into the water, there will be a whole bunch of other countries that will follow suit, eventually perhaps even Canada. I would say, and this isn't a knock on my own government or the Ministry of Health in Canada, but I would say the medical establishment, and I'm more familiar with the medical establishment as a longtime doctor than I am as a member of parliament. I would say the medical establishment is by its nature risk averse. People don't get to become chief of staff in the hospital or the heads of hospital if they're the kind of people who rock the boat, who may take chances. I think if you're deciding who to promote into those positions, you're looking for somebody who's not going to do anything which could get you into the news, could be a source of criticism, and as a result, those positions are populated by people who tend to be followers, tend to be people who don't want to get into any problems, who are risk averse. And so I think the whole medical establishment, and I think that's part of what we see has been the global resistance towards this, has been because I think that population generally is so risk averse. And in good times, that might be a very desirable thing. And as a doctor, I'm exceedingly risk averse. And you can talk to some of the nurses I work with in emergency room and say, oh, Powlowski's sitting on the fence, he's sitting on the fence. Well, sometimes that's the best thing to do, is sit on the fence till you have to act. And when you have to act, you have to act. But you can't be, if you're an emergency room doctor, you can ask Anand, if you're a real nervous Nelly doctor that's afraid to take any risk, you're going to watch a lot of people die, because there'll come a point where you have to do something which, yes, may incur a risk. However, you believe and probably the benefits outweigh the risks, and that happens all the time in medicine. Whether it's like surgery, every time someone operates on you, there's a risk, but the benefits outweigh the risk. Every time you're started on medication, some more than others, there's a risk. Every time there's procedures done, you're given contrast, there's a risk for everything, and it's a matter of weighing the benefits and the risks. And so the same with regulators and people in decision-making positions with policy, that some risks are worth taking. And certainly when you're looking at a pandemic and and given those numbers, 1 million deaths, the havoc wreaked on the economy, putting all those millions of people into poverty, the other deaths, not only in developing countries, but in Canada, United States, because people aren't going to the hospitals because they're worried of catching COVID. They're not getting investigated for their colon cancer, for all their other medical problems. So you weigh those risks, the risks of the challenge trials versus the risks of those things. In my mind, it's clear it's unethical not to do them. But in partly our writing the letter was, I think, an attempt to influence all those decision makers to start thinking about it, because I think the knee-jerk reaction is no. But I think hopefully, and I don't know if with that letter, we got interviews afterwards, the National ran, I don't know if you saw that, Josh, our national Canadian Broadcasting Company ran a 10-minute piece on it that was quite pro-challenge trials. But I think the global movement, it may, whether the United Kingdom was noticing or not, but I think the fact that there's been a global movement and people around the world have gradually more and more been pushing for this. Nobel laureates, people in Oxford University, parliamentarians in Canada, all are pieces on the national, all that I think begins to actually start to change people's mentality and to realize that perhaps we have to take a risk. And I know I'm going on and on, but you know, there's risks entailed in everything in life. I mean, if you don't believe that we should allow people to take a risk, we shouldn't allow people to go into the police. We certainly shouldn't allow them to become firefighters. And like, what the hell, we're putting people in the army. That's a real big risk. And we're asking to people to take on that risk for the sake of society. And then to say, no, you shouldn't allow young people to take on the risk in terms of ending a global pandemic seems to me kind of a little bizarre. And, you know, if we were back in 1942 or 43 now, would Canada be saying, no, we don't want to land on the beaches of Normandy. Let's let some other country do it first. Let's let the Sri Lankans go first. And when they start opening their Tim Hortons in France, we'll come afterwards. So hopefully we have a little more cojones than that in Canada. So.
I agree completely. I think it's unconscionable that, you know, we say that, you know, it's perfectly acceptable, for example, liver transplants, kidney transplants, high risk for fun. I mean, I used to do some pretty risky things when I was a bit younger in terms of just recreation. And then to say that you can't do it for completely altruistic reasons where the potential benefit is just so massive, it makes no sense to me. I will tell you, I think most physicians that are on the front lines of this, that actually take risks, people who are in emergency, like Marcus, intensive care like myself, who are used to managing risk, I think most of us would say absolutely.
Thanks to both Dr. Kumar and MP and Dr. Powlowski for that answer. The next question comes from Mark, who says, I'm a 44-year-old male and I would say healthy. Am I not qualified for a human challenge trial because of my age? Perhaps either Dr. Kumar or Josh could take this one.
My comment would be that I think that you really want to focus on the youngest people who have the lowest risk. And frankly, if the risk was lowest for a 44-year-old, I would be perfectly okay with that too. But I think you focus on that group, and so I would not recommend broadening it out. But you know, those are, you know, political questions in part as well. So.
Yeah, and I'd add to that. Well, I can sort of give a prediction more than a recommendation. And so, you know, the prediction is based on the World Health Organization. When they put together a kind of draft blueprint for how these challenge studies might be conducted, they recommended 18 to 25 as the age range, especially for the first challenge studies. And I do think the first challenge studies are likely to be the most cautious ones because it's the first time we're trying this with SARS-CoV-2. So I think that those early studies are going to be really restricted and probably be 18 to 25. I think there's a chance that the British studies might be 20 to 25, for example. you know, I'm 35, so I wouldn't be eligible to participate, even though I'd like to. And, you know, our view at One Day Sooner, you know, so we think that each additional kind of amount of risk should have an extra benefit attached to that, right? So if there's no additional benefit of my participating in a challenge study as a 35-year-old compared to a 25-year-old, then that extra risk, which is something like 2.5 times in terms of the risk of death, that wouldn't be justified. You know, that said, I think there's some reasons that it might make sense to have older people participate in general. And so, you know, looking at the risks of infection by SARS-CoV-2 in people who are healthy, you know, age 30, age 35, age 40, you know, I think if it were up to 1 day sooner, we might think that an age limit of 40 might be more appropriate. But that's you know, that's sort of maybe a kind of guess on our part. And I think the biggest standard should be this thing of, you know, is there going to be additional benefit commensurate to the additional risk? And that's ultimately going to be decided by the team that is doing the clinical trials. I think that over time, as there is more effective treatments, as the vaccines, you know, there's more evidence of effectiveness and we have better sense of correlates of protection, you might imagine the age range expanding. But I think early on, I would expect 18 to 25, 20 to 25 or so, maybe 20 to 30, at least until certainly the end of the first quarter of 2021 and probably a little bit later would be my prediction.
Thanks, Josh. I think we have time for maybe 1 or 2 more questions. I'm going to first steal a question, which someone asks, how can I get involved? How can I sort of help out with the cause, even though I'm not eligible for the trial? And as I linked in the chat just now, there was actually a recent op-ed from a 70-year-old Nobel laureate arguing in support of challenge trials. And there are many ways that, you know, as MP Powlowski was talking about, we can help increase support for challenge trials. I'll send a document after the call called our Get Involved document that outlines ways that volunteers can write op-eds, speak with journalists in support of challenge trials. So one additional question, just one moment, is from Kent, which is, why do we need a placebo control group in challenge trials? Is it worth the risk to run a challenge trial in which you don't first give someone a vaccine candidate and then expose them to the virus, but give them a placebo and then expose them to the virus? Dr. Kumar, do you have a take on this?
Sure. You know, it was a question I asked myself, but then I thought about it, and yeah, you need a comparator group. So you might find, for example, that when you challenge people with a virus, say, rather than injecting it, you inhale it. You might find only 50% of those get infected. And if you then, you know, have an ineffective vaccine, you could, and only one arm, you could then end up thinking, whoa, we reduced it from 100% to 50%, but you never actually checked to confirm the 100%. So you do need a placebo arm to make this work. But by the way, that's not to say that once you know the person is infected, to the extent that we have any treatments that have some degree of efficacy, like remdesivir, that's not to say once you know they're infected, you can't now give them those drugs to try to ameliorate the disease. You can still do that.
I think the issue of the placebo and how many people to put in the placebo group, I think is an issue that would have to be figured out. I don't know if that was in Josh, whether you know, was that what was said in the WHO document on the placebo group, but I've heard it suggested too that you would have a much smaller placebo group than a treatment group. So if there was like 50 people in the challenge trial, 10 would be placebo, 40 would be vaccine, just to minimize, because really with the placebo group, you as Anand said, you want to make sure that in fact, you're giving people enough virus to get them infected. But on the other hand, obviously, you're not doing them any favors. We're doing the world a favor in using them in the study. But unlike the people with getting the vaccine, there's probably more of a risk and less benefit. So I would think that and I don't know, Josh, you've been very involved with this. I don't know what people are talking about, but it seems something that has to be kind of to be determined as to how big a placebo group there would have to be.
Yeah, and I think so. The WHO report is mostly focused on, doesn't really address this question. It is mostly focused on the first challenge study, what's called the infectious dosing study, when you're just testing the virus and not the vaccine. So you're testing the amount of virus to give to people that could, that would reliably cause people to become infected, but not too sick. And so you start at a very low level and you slowly work your way up. And there's also a lot scientifically we can learn from those studies. And that's the first study you need to do. And so the WHO report didn't really address this placebo question. I think that most of the doctors and scientists we've talked to who are developing challenge studies concurred with Dr. Kumar about needing a placebo group and probably needing a placebo group that's basically equal in size to the treatment groupers, kind of traditional in challenge studies. But there have been some different creative suggestions and approaches that one might take. So for example, one thing we'd like to see is a number of different vaccine candidates being compared against one another. And you might have a common placebo group for all of those at once.
Absolutely.
And so to do that, though, I think, that really is going to require, that's something that requires more coordination because you need to have, a good amount of this kind of biocontainment capacity. And that's going to require a few different sites potentially across the world. And that's why it's so important to be preparing now and having different countries and different groups be thinking about this actively so that, early in 2021, if challenge studies are going to be useful and if they're going to be ready, they can be used as widely as possible for testing different vaccines and making sure that we can get vaccines as quickly and as well developed and as safe as possible.
Great. Yeah, thank you to all panelists on that question. So we are now at an hour, and just in a moment, I'm going to create breakout rooms for us to have a bit less of a structured time to speak to one another for Canadian volunteers to get to know one another a little bit. But I'd just like to say one final thanks to all of our panelists. One Day Sooner was created just by volunteers who are interested in taking part in a challenge trial. And the fact that we now have 38,000 volunteers in the support of prominent politicians and scientists is really remarkable, and we're incredibly grateful for it. So thank you to the panelists, and to everyone in the audience. After the call, I will send over several resources to get more involved with One Day Sooner's advocacy efforts. So with all of that said, I'm going to create breakout rooms. The panelists can feel free to join, but are under no obligation to. I'll see you all there.
Thanks, everyone.
Thanks, Josh. I'd like to have a quick word with you.
Sure.
If we're going to have a room. Josh, I just want to say, don't get too wrapped up in the biocontainment issue. Like I said, if you just have the same level of containment as you have on a hospital ward, you just have a dedicated ward for these patients. That's what we're doing with patients right now, kind of thing, right? And the subjects wouldn't be any different than that. So I don't think it's a particularly difficult issue.
Thank you. I don't think I'll go to the subgroups, but thank you very much for allowing me to participate. You're doing great work, and good luck to you all.